transverse myelitis because it's a segmental inflammation of the spinal cord, right? So, like the rest of the myelitis, you have them sometimes ascending, right? It can ascend or it can descend, like in Guillain-Barré syndrome, for instance. Guillain-Barré, does it ascend or descend? Ascend. Good. Botulism? Descend. Exactly. So those are all inflammation of the spinal cord. Sometimes they ascend, as in Guillain-Barré, or sometimes they descend, as in botulism. But transverse myelitis is called transverse myelitis because it happens at a segmental level. And the way you know transverse myelitis in the clinic is that when you examine the patient, there is a very sharp sensory demarcation. So if you test in the dermatomes, especially in the trunk, you will see, for instance, that, the patient cannot feel anything below the navel. And above the navel, they can feel. So the demarcation is very sharp. So when you have transverse myelitis, you do have that sharp demarcation. That's how you know it's transverse. For the rest of it, like Guillain-Barré and botulism, sensory demarcation is not as sharp when you do your physical examination. So when you read any questions or you see any patient where sensory demarcation is very sharply defined, clearly stating that the patient feels below the nipple and they don't feel anything above the nipple, this is kind of sharp, especially on both sides like that. Okay, what causes it? Viruses, herpes simplex, varicella, cytomegalo. It could be bacterial, as a mycoplasma, Lyme disease, and also cat scratch disease. And anytime you see somebody, they talk to you about somebody's pet, always remember those pet and pest-related diseases. Okay, and then it could be non-infectious. I was telling you about this. Is the reason many parents now don't want to take their children for vaccination, but these are so rare that you deprive the kid about for fear of something that may not even happen. Now there is something called neuromyelitis optica. Neuromyelitis optica is actually a transverse myelitis that also involves the optic nerve and leads to blindness. So transverse myelitis plus blindness is what is called neuromyelitis optica. That's why you call it NMO, or the Vicks disease. All right? This is not a very common problem. And symptoms, of course, like every spinal cord problem, is pain, is paresthesia, is paresis, which is weakness, or paraplegia, which is paralysis. All right? You get paraplegia if it's a thoracolumbar lesion. You understand that, right? And then you get quadriplegia if it's a cervical lesion, right? Depending on how high it is. And if it involves the high cervical segments like C3 to C5, you begin to get diaphragmatic paralysis. And when people paralyze their diaphragm, they go into hypoventilation. That is why whenever we have ascending diseases like Guillain-Barré, we monitor the minute ventilatory capacities to monitor the maximal voluntary ventilation, MVV, to monitor the strength of the diaphragm. Because once you begin to get the involvement of C5, C4, C3, the diaphragm becomes paralyzed, and if it is lower down in the lumbosacral area, you can get bowel and bladder incontinence, right? Because of the sacral sympathetics. The sacral parasympathetics, not sympathetic. All right, and then when you examine the patient, you will see lower motor neuron signs at the level of the lesion. You remember that, right? Okay, you can't forget that. There's atrophy, fasciculations, flaccid paralysis, and hyporeflexia. And then below the lesion, you get upper motor neuron signs. So you get spastic paralysis, hyperreflexia, then you get Babinski reflex, and you get clonus. I'm hoping that during your rotation, you will see clonus because it's a very interesting and clinical entity to observe. All right? How do you diagnose it? You always have to do CT scan or MRI, okay? But what is it that clues you in to transverse myelitis, it is usually, but not always, bilateral involvement. Bilateral involvement. So transverse myelitis is not an hemisection, it's a transverse. It affects the entire segment of the spinal cord on both sides, right? So it's a bilateral involvement, and then you have a clearly defined and demarcated sensory level. When you do lumbar tap, you will see increased cells, like we said, and increased protein, okay, with high IgG index. And of course, neuroimaging is always positive, okay? Now, remember what I told you, that one of the things that separates transverse myelitis from Guillain-Barré or botulism is the fact that the inflammation spreads up and down the spine. That is unusual in transverse myelitis, but it doesn't really can't occur. It is so unusual that whenever we see that, that is when transverse myelitis is called longitudinally extensive transverse myelitis. Okay? So it warrants a special name, longitudinally extensive transverse myelitis. That is what we early ETM. Okay? Now, whenever you see transverse myelitis, there's some things you want to consider in terms of differential diagnosis. Spinal cord compression can present like transverse myelitis, but it's never going to be symmetrical, right? And when you see spinal cord compression, you think about primary tumors like astrocytomas or secondary metastasis like from prostate cancer, right? Spinal cord injury, usually you have an evidence of injury, right? A very common one is whiplash. When you have severe whiplash, when you have compression fracture, you can actually compress the spine, right? And of course, spinal cord degeneration as a result of B12 deficiency. So these are all differential diagnoses of transverse myelitis, and giving you the clinical features. For B12 deficiency, it tends to affect the dorsal column, right? And remember that is the column that is responsible for your vibration and proprioception, right? Whereas temperature and pain is in the anterolateral column of the spinal cord. You remember that, right? Okay. And then spinal cord infarction, like it could be anterior, it could be posterior, right? When it's anterior again, you present exactly like you present with compression. What is your clue to spinal cord infarction? The patient has suffered hypotension. There is a hypotensive episode that antedates or precedes the paralysis or weakness of both legs. Okay? So a typical example would be somebody that came into the hospital for, say, for instance, pneumonia, and then something happened in the hospital, they go septic and they go into shock, and they go into some kind of cardiorespiratory arrest and end up in the ICU. Then they are resuscitated and revived and brought back onto the floor. And when it's time for them to get out of bed, you realize they've lost strength in both legs. That picture should make you think more of spinal cord infarction, right? And of course, spinal cord transection. Brown-Séquard. Did Katie talk about this?
Yeah.
Okay, good, all right. How do you treat it? You see, the reason many of these conditions are not so popular on the exam is because it does not really matter, right? Whether it's MS, you misdiagnose as transverse myelitis or something, invariably is corticosteroids to moderate the inflammation, right? That is why we don't even try as much as possible to make a specific diagnosis, because invariably, what are you going to do? The treatment is cheaper. So when treatment is cheaper, then we do that. Did I?
Yeah. It's with the...
Oh, okay. So when treatment is cheaper, then investigating a specific diagnosis, we go for trial therapy, right? Yeah. Of course, if that does not work, then you do what we always do. We do plasma exchange therapy, IV immunoglobulins, or immunosuppression, right? If you think that the patient may have infection based on the history, you can start antimicrobial with corticosteroids. Okay, just like we do with skin rash, right? When you're not sure whether it's fungus or allergy, you give them nystatin triamcinolone so that you can, whatever it is. Okay, we can do the same thing with this type of infection. So that is it really about CNS inflammation. That was the last one. You just need to remember these things, right? Meningitis, encephalitis, and then myelitis, transverse myelitis specifically. So let's look at these three. What do you think? 26-year-old college students with recurrent episodes of meningitis. What is that going to be? Varicella, right? How about this 16-year-old rising senior in a boarding high school? Huh? Neisseria. And this 62-year-old alcoholic? Listeria, exactly. How about this 28-year-old college student with encephalitis? Herpes. How about this 48-year-old patient with AIDS? Crypto. And this 6-year-old kid with congenital dysfunction? Rasmussen. And what is the recurrent meningitis you get with VCG called? Mollaret, right? Remember?
Yeah.
Okay, all right. Okay, so let's go to the lecture for today, which is really I think this is my last lecture, right?
Yeah.
Do we have a review? No review, right?
Is it one more thing?
What?
This is supposed to be the last lecture for neuro.
The neuro?